Hi guys, Dr. Warwar here from Pinnacle Fertility in Columbus, Ohio. Wanted to talk through the updated Recurrent Pregnancy Loss Committee opinion. This was updated by the American Society for Reproductive Medicine just recently in 2026. So there are many parts of this article that are very high yield, but I really like this table and I want to talk through how they break down treatment or management recommendations into groups of standardly recommended or possible benefit but limited conflicting studies, and then the last column being treatment that's proven to be ineffective or no evidence of benefit. Okay, so this first one are standard recommended treatments. So this is standard of care, what you should be expecting from your physician with a recurrent miscarriage treatment strategy. Preconception optimization of any pre-existing health conditions such as high blood pressure, lupus, diabetes, things like that. Psychological support, treatment of antiphospholipid syndrome, which is something that's standardly screened for in this situation. Treatment of that syndrome with blood thinners, treatment of overt thyroid disease. So we're looking for a TSH greater than 4 in that situation. And genetic counseling if there's a known parental translocation or issue with a chromosome analysis, and treatment of high prolactin levels. Okay, so this section here is treatments of possible benefit with limited or conflicting studies. So this is probably the biggest kind of conversation piece that I have with my patients of do we do these things, do we not? And it's really a shared decision making for each of these situations, what makes sense to assess and manage and treat for. One of them is correction of the uterine cavity abnormalities. So typically we're doing a evaluation of the uterine cavity with either a hysteroscopy or a saline sonogram, looking for things that basically shouldn't be there. Polyps, fibroids, a uterine septum, which is like a dividing wall in the uterus, and then removing them if they shouldn't be there. Addition of progesterone support. This is a big one where I typically tell my patients, look, too much progesterone is never a bad thing as long as it's taken at the right time during your cycle or with a positive pregnancy test, but technically hasn't been proven to decrease risk of miscarriage. Treatment of chronic endometritis, so sampling the lining of the uterus for inflammatory cells and then treating with antibiotics. Looking at sperm DNA fragmentation, again, a conversation I have with my patients, is it appropriate to test for this? What would we do differently? Just talking about lifestyle optimization or modifications up front, maybe without even doing the test. Using metformin for women with PCOS, doing IVF with genetic testing of the embryos. This is, again, a very big shared decision-making point to discuss with patients. Age, prior history, prior pregnancy history, chromosome analysis of the egg and sperm source all come into play there in making that decision. And then use of donor gametes would be in very unique situations, would be a recommendation. Okay, and finally, and potentially the most important category is treatments that are not effective or have no evidence of benefit. So use of empiric aspirin or blood thinners without an indication, so in an absence of that antiphospholipid syndrome. Treatment of endometriosis or adenomyosis. Again, not that treatment for those things is bad, but treatment does not decrease the risk of subsequent miscarriage. Treatment of inherited blood clotting disorder, so screening for things like protein C or protein S deficiency, factor V, Leiden, those things just for recurrent miscarriage are not indicated, and treatment does not decrease the risk of subsequent miscarriage. And then thyroid hormone supplementation in patients with just elevated TPO antibodies or a TSH less than 4. So again, we're really looking for overt hypothyroidism to really reduce the risk of miscarriage, and that's where treatment comes in. And then finally, things like IVIG, intralipids, prednisone, these things have unfortunately not been shown to be beneficial in reducing the risk of miscarriage. These things can produce harm and they can be very expensive. So a lot of fertility clinics, because they're not evidence-based treatment, will not offer these. Hopefully this was helpful and just a nice review of what treatments are indicated and what treatments are not in situations of recurrent miscarriage.